So about nephrotic syndrome, dropping the glomerulonephritis topic, we are jumping to nephrotic syndrome. So let's discuss nephrotic syndrome briefly and we'll elaborate later. So that, okay, because all the renal pathology is subcategorized into nephrotic or nephritic. Nephrotic is a constellation of features, constellation of symptoms and features that mainly consist of heavy proteinuria. The proteinuria can be given per meter square, per body meter square per hour, or it can be given in per day. So in last class we said 3.5 gram per day, isn't it? That is massive proteinuria, isn't it? So you can add 40 milligram per meter square per hour as well. Some of the teachers are fond of this data also. Alright, Raksha, am I audible?
Yes, ma'am.
Okay, so heavy proteinuria more than 3.5 grams per day. Hypoalbuminemia. The level of serum albumin reduces to less than 2.5 gram per deciliter. Edema that can be massive up to anasarca. What is anasarca? It is generalized edema, entire body edema, and hyperlipidemia that goes above 200 milligrams per deciliter. Okay, you can add, these are 4 important points that characterize nephrotic syndrome. However, you can also add lipiduria. Because of hyperlipidemia, there is also lipiduria along with proteinuria. Alright, this demographics and epidemiology. This nephrotic syndrome is very commonly seen in the children in pediatric age group in comparison to adults. The ratio is 1:15, means it is more common in children, 15 times more common in children. And per year, out of 100,000 population of children, 2 to 3% gets nephrotic syndrome. Okay, and its ratio is quite higher in the Asian population. As I said in previous class, the reason may be the geographical variation, the hygienic concept, poor sanitations, crowding, lack of treatment, lack of approach, all these things. Now, surprisingly, 90% of the nephrotic syndrome is idiopathic. What do you understand by idiopathic? Yes, unknown cause. The cause which is the physician is not able to localize. We don't know the cause after batteries of evaluation, and it is called idiopathic. Or because this medicine is a scientific study, and science is every day searching some new things, so we don't say unknown, we say idiopathic, because the physicians are still idiotic about it. They don't have idea of it. They are still in the process of search. So 90% of the nephrotic syndrome is idiopathic and mainly constitute minimal change disease, mesangial proliferation, and focal segmental glomerulosclerosis. Out of them, the most common disease that includes the nephrotic syndrome is minimal change disease. We are talking about primary nephrotic syndrome, idiopathic one. There are secondary also, like diabetes mellitus and other portions of the focal segmental glomerulosclerosis. So you will be asked most common cause of nephrotic syndrome, or most common disease that cause nephrotic syndrome is minimal change disease. And as the name suggests, why it is called minimal change? The symptoms are of nephrotic syndrome like massive proteinuria, massive edema, hypoalbuminemia, hyperlipidemia, lipiduria, everything is there. Then why it is called minimal change? Because in biopsy or in immunofluorescence or under electron microscopy, the changes in kidney is very minimal. Okay, this is morphological change which is very minimal in kidney, so we call it minimal change disease. Other secondary causes comprise 10%, and they can be renal causes or extra-renal causes. Among renal causes is membranous nephropathy and membranoproliferative nephropathy. Okay, the proliferatives are usually glomerulonephritis. So membranous nephropathy and NPGN Balsawami, membranoproliferative glomerulonephritis. So you should be aware of the term glomerulosclerosis, nephrosclerosis, nephropathy, glomerulonephritis. Just like post-streptococcal glomerulonephritis, there is another glomerulonephritis that is membranoproliferative, and one is rapidly progressive glomerulonephritis. Okay, PSGN, MPGN, RPGN. So these are GN, glomerulonephritis. Some other disease like mesangial nephropathy, mesangial proliferative nephropathies, membranous nephropathies. So they are nephropathy. Focal segmental is glomerulosclerosis. All right. Then comes extrarenal causes, which are also included in those lesser 10% cases. That is infection, some other infections that can be non-specific, bacterial, viral, parasitic. Drugs, all the drugs, they get filtrated in kidney, and any drug we take has some load on kidney, has potential to damage our kidney. Okay, our kidney function. So we should be very judgmental while taking drugs. If we really need drug, then only we should take drug. Not like that I'm having mild headache and I should take a 500 mg paracetamol. It should not be the habit. The habit should be, we should relax, we should wash your face, isn't it? Can take a hot cup of milk or tea or coffee, and after non-medical treatment only we should jump to medical treatment for milder illness to protect our kidney, and we should drink lots of water for progressive filtration. Then tumors, the neoplasia, they can also cause nephrotic syndrome. Many tumors have burden on kidney because of tumorolysis, or primary renal tumors can present with nephrotic syndrome. Some systemic diseases like diabetes mellitus, systemic hypertension, and many other chronic diseases can cause nephrotic syndrome. Allergic reaction, I will give you one example which I have seen in my career, which was very surprising, that a person presented with nephrotic syndrome, there was nothing, no primary cause, no other secondary cause. We evaluated everything, and surprisingly he had history, a very recent history, a day 1 kind of, or day 2 had bee sting. So even insect bite, especially bee sting, can cause allergic reaction which can present with nephrotic syndrome. All right. Then circulatory disorders like cardiac disorders or thromboembolic events or infarction or hypovolemic shock, all these can also cause nephrotic syndrome. Pathophysiology, main thing in the context is there is hypoalbuminemia. Hypoalbuminemia causes decreased oncotic pressure. Because of decreased plasma oncotic pressure, there is transudation of fluid from intravascular compartment to the interstitial compartment, and that accumulation of fluid in the interstitial space, abnormal accumulation of the fluid in the interstitial space is edema. All right. At the same time, because there is positive feedback from the body that there is less albumin, so liver synthesizes protein, and because of it, because side by side lipoprotein gets synthesized, there is lipid also and protein also. Though liver synthesizes lots of protein, but it cannot compensate albumin level, so there is hypoalbuminemia. And because there is deactive synthesis of lipoprotein, there is hyperlipidemia. Clear? Do you know why there is hyperlipidemia? Got it? Yes. Then at the same time, what happens to intravascular volume in nephrotic syndrome? Yes, I discussed in last class. What happens to the intravascular volume in nephrotic syndrome and what happens in nephritic syndrome? It is a common sense. Most of the fluid is going to interstitial space, isn't it? And at the same time, albumin level is low. So what is the role of albumin? It maintains the oncotic pressure. It retains the volume within the blood vessel. Because it is low, so volume will go out, right? So intravascular volume is lesser, while it is more in nephritic syndrome. That's why there is hypertension in nephritic syndrome. One of the important feature of nephritic syndrome is, along with hematuria, it is hypertension. Oliguria and edema are secondary. They may or may not be present, or they may be mildly present, but hypertension, hematuria is quite consistent in nephritic. Here the intravascular volume is low. So what happens? The renal perfusion pressure is also low. Okay, so this will cause stimulation of antidiuretic hormone. Whenever we have negative and positive feedback mechanism in our body, whenever something is low, we give signal, body gives signal to resynthesize or more synthesis. When it is in adequate amount, there is signal of less synthesis. So there is water reabsorption in collecting ducts because of activation of renin, angiotensin, and aldosterone system, and there is loss of tubular reabsorption of sodium. Okay, and because of that, all these things, there is accumulation of fluid in the interstitial space because of transudation, and there is edema. So you can see here, okay, these are the filters. So when there is hypoalbuminemia in the blood, fluid is leaking out and going to the interstitial space. Now we are going to discuss about idiopathic nephrotic syndrome. Okay, as we said, idiopathic, there is no cause, we don't know the cause, and the primary cause can be membranous and membranoproliferative. Alright, there's something wrong here. So we know the idiopathic, the likely idiopathic causes. Now how will patient present the nephrotic syndrome clinically? There will be history of flu-like illness. Okay, there will be generalized ill feeling. The patient is not perfectly well. There is malaise, lethargy, anorexia, a kind of weight gain because of edema. All right, and the prominent edema, whether it is ankle edema or periorbital edema, right? And then we have to take history whether there is hematuria or oliguria or not to rule out nephritic syndrome. Sometimes there is overlapping of the features. Okay, we have to examine. The patient will present as if he is having some flu, some viral illness, but it is something else actually. We have to evaluate the vitals, BP, height, weight, whether there is anemia or not, what kind of edema is there, is it associated with lymph nodes, because we have to rule out the other pathologies also. And because the edema is massive, it does not only occur in the interstitial space, it goes in the body cavities. There can be pleural effusion, pericardial effusion, and ascites also. That is peritoneal effusion. You see the periorbital edema, the child face is so puffy. You can compare the leads with the child sitting behind, maybe the sibling, and there is remarkable periorbital edema. And we ask the patient to collect the urine, and the foremost test we do is very simple test, urine analysis, deep stick test. Okay, deep stick test has different level of color index with the reagent coated, and we see for protein. If it is 1 and 2 or 1 or 2 plus, we think of nephritic syndrome, but here the proteinuria is massive proteinuria, that is 3 plus or 4 plus, that indicates more than 3.5 gram per deciliter, okay, per day. Now we ask the patient to collect 24-hour urine, and as I said in the definition of nephrotic syndrome, either it is 3.5 gram per day or 40 milligram per meter square per hour. This 40 milligram per meter square per hour can be estimated in 24 hours urine sample collection, while the 3.5 gram per day can be estimated by deep stick in any one of the urine sample. Okay, so we do subsequently. Then we see the protein to creatinine ratio. As per the definition, you have to mention massive proteinuria, edema, isn't it? And proteinuria more than 3.5 gram per day or 40 milligram per meter square per hour, you have to mention hyperlipidemia and lipiduria. However, if you add all these features in details, apart from the definition, in definition you don't need to add, in any other types of interrogations, then you are credited more. So very rarely there are microscopic hematuria, which you may not mention because it is prominent feature of nephritic syndrome. Why I am mentioning here? Because all the microscopic hematuria is not nephritic, because in nephritic we are supposed to see gross hematuria, isn't it? Where else you see microscopic hematuria apart from this nephrotic and nephritic, Neha? Where else can you see microscopic hematuria apart from this nephrotic and nephritic syndrome? Renal calculi. You should mention renal calculi, which is very, very common pathology. All right, it is renal pathology where you can see, say, because of the erosion of the renal tubules. You can see this hematuria. All right. Anyways, so you should know all other cause also. Okay. So we are talking nephrotic syndrome. I just asked because this is general feature. This is general feature. Okay. So we were talking about the different evaluations. All right. So as per the definition, what are the things we are need to evaluate? We are supposed to evaluate there is whether there is proteinuria or not, edema or not, whether there is uh, other associated features of edema like pleural effusion, peritoneal effusion, or pericardial effusion. We have to rule out nephritic syndrome by ruling out hematuria or oliguria or hypertension. Okay, at the same time, we have to evaluate for hyperlipidemia and lipiduria. So this nephrotic syndrome, it mainly includes minimal change disease which has no renal morphological features. If we do biopsy, biopsy is done in very severe cases. Okay, biopsy is done in very severe cases, and this sometimes goes as a diagnosis of exclusion. So we have to do lots of investigation. All right, and this disease is mostly common in the pediatric age group. Now we will switch off to, so this was brief introduction of nephrotic syndrome, which we also tabulated in the form of difference between nephrotic and nephritic syndrome. Now our main topic of discussion is rapidly progressive glomerulonephritis. All right, it is type of glomerulonephritis. It is included in nephritic syndrome. So what is RPGN? It refers to a clinical syndrome which is characterized by there is rapid loss of renal function. In nephritic syndrome, there is loss of renal function. We have understood the renal function test is altered. There is loss of renal function. However, as the name suggests, rapidly progressive. In PSTN, what we said, the prognosis is better. The loss is of some duration and can be self-healing, isn't it? But here, the loss of renal function and the damage to the kidney, both is very rapidly progressive. So the name of the disease refers to a rapidly progressive glomerulonephritis. How will it present? What happens if there is loss of renal function? There is either oliguria or up to anuria. Anuria means complete cessation of renal output or urinary output. Now, basically it is glomerulonephritis, and there will be features of glomerulonephritis. So what are those features? First, there will be presence of microscopic hematuria. Hematuria is basic feature of nephritis. In PSTN, the hematuria used to be gross. However, here the hematuria will be microscopic. So, typically the RBCs will be dysmorphic. So we can also mention a term dysmorphic erythrocyturia, or simply we can say microscopic hematuria with dysmorphic RBC under microscope. Okay, then the erythrocytes take the shape of the cylinders, the pencil cells like structure. So we say erythrocyte cylinduria. Okay, these are fascinating words, but actually it depends upon the dysmorphogenesis of the RBC. And there is glomerular proteinuria. So there is loss of renal function which can be present with oliguria and anuria along with the urine analysis showing microscopic hematuria and dysmorphic RBCs. Now this RPGN is also known as crescentic glomerulonephritis. So if you remember the term crescentic glomerulonephritis in RPGN, you can easily describe the morphology, and it is very favorite questions of most of the examiners, frequently asked in theory as well as viva. What is the morphology in RPGN? What are the clinical features, whether it is nephrotic or nephritic, isn't it? And basically morphology. So I hope you all know what is crescent. You know crescent? Have you seen the crescent moon? I'm sure you all must have seen. So morphologically, RPGN presents with extensive crescent formation. But now where crescent formation? Where is this crescent formation? So this crescent formation is the kidney biopsy. The shape of the glomeruli takes the shape of crescent. So depending upon the severity of disease, there is degree of crescent formation. If mild crescent formation, the RPGN is mild. If the crescent formation is more moderate or severe, the RPGN will be moderate or severe clinically. Okay. And the response to severe injury to the glomerular capillary wall is non-specific, means there is no typical characteristics. Okay, all right. So let's see this crescent formation. Let's compare the normal glomeruli and the crescent formation. Okay, so I hope you are able to identify. We discussed this slide previously also. You see here there is GBM in the green lining. The outer lining is Bowman capsule, the pinkish one, and there are podocytes. Inside there is endothelial cells. There are three important cells. One is visceral food process, that is also known as podocyte, endothelial lining which lies inside, and the interstitium that is called mesangium, and there are mesangial cells. So whenever there is hypercellularity, whether there is mesangial proliferation or there is visceral food process proliferation or endothelium. Alright, and then GBM itself is a glomerular basement membrane, consists of collagen, basically the type 3 type 4 collagen. So there can be GBM thickening. Now you see in any glomerulonephritis what happens. There is cellular proliferation and there is accumulation of inflammatory cells. Alright, sometimes there can be thickening of the glomerular basement membrane, or in glomerular disease the glomerular basement membrane becomes porous. Okay, it becomes porous, so there is losing of plasma proteins and fibrin are going outside. And as per the part of reaction, there is interstitial, there is role of infiltrating macrophages and fibroblasts, and there is also proliferation of parietal epithelial cells. So all these cellular components, what? The parietal epithelial cells, the interstitial fibroblasts, and the inflammatory macrophages, they get proliferated and they push the glomerular structure at one side, and there is formation of crescent. I hope you are able to concentrate on picture and you are seeing the slide. Is the crescent clear, Raksha? How the crescent is forming?
Yes,
you can see the picture in the clockwise direction. First picture, then the clockwise second, third, and fourth, like that in a circle. And you see it is the glomeruli basically is pushed towards one side, the basic structure, and because of proliferating visceral food process or podocytes along with fibroblasts are forming the crescents. Now this is the diagrammatic picture. Now you see the real histopathologic picture and you can compare how crescent looks like. So many of you have seen this glomerular structure in your books. The outsides are renal tubules and the central is tuft of capillaries, which is glomeruli. The cellularity, 2 endothelial cells per capillary of the glomerulus and 2 to 3 visceral food process. Similarly, few mesangial cells. So that is normal cellularity. Now you see the normal glomerulus is pushed to one side, so it is looking hypercellular, the darker area, and the lighter area is crescent because of proliferation of fibroblast and the visceral epithelial cells. So this is this crescent, the demonstration of this crescent under my light microscopy or fluorescent microscopy. Okay, there is diagnosis of this RPGN. Now this, depending upon the different changes, RPGN, rapidly progressive glomerulonephritis, is categorized into 4 main types. Okay, and this is very important question, so you must know it. Type 1 is known as anti-GBM. Now this single rapidly progressive glomerulonephritis, RPGN, actually has a constellation of many renal diseases. Okay, depending its type, it includes many other diseases. Just like nephrotic and nephritic syndrome, there were many diseases included, like minimal change disease, focal segments of glomerulosclerosis, mesangial proliferative were included in nephrotic syndrome. This RPGN, PSGN, and other nephritis are included in nephritic syndrome. Likewise, even in RPGN, there are many other secondary diseases. So what are they? Type 1 is characterized by there is formation of antibody against the glomerular basement membrane. So it is known as anti-GBM antibody disease. Anti-GBM antibody disease, type 1. So you have to mug up. This slide has to be mugged up so that you can answer it properly. Type 2, immune complex. Now what are the immune complex deposited disease? They can be IgA nephropathy, Best example we just studied in the last class is post-infectious glomerulonephritis, where the immune complexes were getting trapped in the renal parenchyma and they were damaging the kidney. So post-infectious glomerulonephritis, IgA nephropathy, lupus nephritis secondary to SLE, and cryoglobulinemia. These all are immune complex disease that comes under type 2 RPGN. Type 1 RPGN, anti-GBM antibody disease. GBM is glomerular basement membrane. Then there are certain cases in which immune complexes are very lesser. We find very less immune complex, but there is demonstration that there is some basis that there is role of immune complex. So they come under type 3 and we call post-immune. Post-immune RPGN, rapidly progressive glomerulonephritis. These include Wegener's syndrome, which is anti-nuclear cytoplasmic antibody. We do anti-nuclear cytoplasmic antibody test basically for vasculitis. I hope you have studied in your first year, ANCA. In certain vasculitis, in polyangiitis and vasculitis, we do this test, isn't it? You remember? These Wegener's are also vasculitis only. So, in association with those vascular disease or vasculitis, there is post-immune RPGN. So it is characterized as whether ANCA positive or ANCA negative. Post-immune RPGN. And the fourth type, okay, it has four features of type 1 and type 3. The fourth type has mixed picture of type 1 and type 3. And probably it is idiopathic. We don't know the cause that is included. Maybe the combination of anti-GBM or post-immune, but morphologically it is combination of type 1 and type 3. Okay. Now what happens in rapidly progressive means ultimately the patient will succumb to renal failure. It is very progressive disease, very deadly disease. It occurs within hours to days and overall duration is less than 2 weeks. The presentation and the course of disease is very fast. And how will we measure that the patient is deteriorating by renal function? We will do renal function test. We will estimate the blood urea, the serum creatinine. Serum creatinine is more sensitive than blood urea, okay? And increase in serum creatinine by more than 0.3. Suppose the patient had 0.7 milligram per deciliter serum creatinine when the patient presented. Now, within 48 hours, it increased by 0.3 milligram per deciliter. By 0.3, not the total digit. So, it means that the kidney is deteriorating fast. Okay, in 1 day or 2 days, there is no increment like that by 0.1 or 0.2 or 0.3. Because do you know the normal creatinine level, normal serum creatinine level? It is very important question again. And you must know the renal function test and their values. It is 0.7 to 0.7 to 1.4 milligram per deciliter. In some lab, it is up to 1.2, but it is very sensitive. And it doesn't mean that 1.2 or 1.3 study it was 1.2, today 1.3 is normal. No, it increases over years, okay, or over months. So in day 1 and 2, even by increment of 0.1, 0.2 or 0.3 is significant, okay. Similarly, if there is increase of serum creatinine more than 1.5 times of baseline, suppose the person used to have 0.5 milligram per deciliter creatinine, and if it is increased 1.5 times of that 0.5, okay, in very short period, then we call it that the person is deteriorating rapidly, and this is RPGN. We are talking about estimating RPGN first clinically. Okay. Similarly, the urine volume gets reduced by 0.5 ml per kg per hour for more than 6 hours. If you say you may not remember all these numerics, so at least you should know that there is rapid deterioration of renal function, which can be evaluated by serum creatinine level and urine output level. Urine in very short time, urine output is remarkably reduced. Say more than 6 hours, there is less than 0.5 ml per kg per hour. Then it is significant. We have to estimate the renal output when you will be in clinical posting. What is the urinary output of the patient? especially in post-op patients. We see urinary output. Why? Because of the surgical event, whether the renal function is impaired or not. Okay, so when you see the patient's chart, there apart from the vitals, the most important other evaluation is renal function test. Similarly, serum creatinine. We have to be very strict in evaluating serum creatinine. So we are talking about acute renal failure that occurs following RPGN. So it takes only less than 2 weeks from hours to days. Now sometimes it can be chronic and go up to weeks to months, more than 3 months. All right. So GFR is reduced more than 60 milliliter per minute per 1.73 meter square of the body surface, or there is evidence of kidney damage. Okay, so clinically there is overall either acute renal failure, sudden onset of renal failure, or chronic onset of renal failure, and depending upon that we will categorize. And renal failure can be estimated by urinary output and serum creatinine. This is the basic knowledge that you have to understand. Renal function can be evaluated by either evaluation of serum creatinine, there is rapid increase in serum creatinine, or the urine output is getting lesser. Okay. However, instead of clinical, more of the morphological questions are asked to the pathology student. But in Viva, we don't spare. The examiners don't spare you in answering the renal function test. So you must be aware of the normal parameters. You are also supposed to do urine analysis test in the lab. In the exams, you are given one practical of 25 marks, two practical of 25 to 50 marks, and you are asked associated questions. So please go through the renal function test also while revising. Okay, so RPGN is actually renal emergency and it can lead to end-stage disease. What does it cause? It can cause tubulointerstitial disease, or glomerular disease, or vascular disease. Clinical approach, we already said we will do loss of evaluation, starting from history to rule out the other causes. We will do physical examination. Okay, we will do routine investigation. So medical person or future medical person must have idea of routine investigation, especially complete blood count, all right, and rule out of the immunological mediated diseases and peripheral blood smear, all right. Then most importantly, urine analysis. As per the definition, I said there will be dysmorphic erythrocyturia or microscopic hematuria with dysmorphic RBC, and RBC cast can be there. And the proteinuria, if there is proteinuria, it should be subnephrotic. If there is nephrotic proteinuria with all these features, it is not RPGN. We have to find out the cause other than RPGN. Okay, and because it has immunological basis, we have to do serological tested like ANCA, or we have to rule out PSGN. Okay, ASO titer. There can be IgA immunopathies, anti-GBM disease, so anti-GBM immunoglobulins has to be estimated. So we are discussing it in a broad terms, all right. Ultimately, this is the gist of what we are discussing. Patient will present with a flu-like syndrome, general illness, malaise. You will find patient erythematous, not only the facial or generalized or other part of body edema like ankle edema. Patient has pleural or peritoneal or pericardial effusion sometimes. The renal function test, you admitted the patient, the renal function test is rapidly deteriorating. Okay, 1.5 times more creatinine is increasing than the baseline level, or it is more than increasing by 0.3 milligram per deciliter in first 24 hours. So rapid deterioration of renal function test is there. There is microscopic hematuria with dysmorphic RBCs. ANCA and other serological tests may be positive depending upon the cause. So we will decide if the patient is stable, we will go for renal biopsy. Renal biopsy is indicated here, okay, to rule out. So if we do renal biopsy, see the beautiful renal crescent you can appreciate in this picture. This is Anti-Gbm Glomerulonephritis, in which large crescent is forming like a cap-like structure just above the glomerular tuft. Is it clear, Raksha?
Yes, ma'am.
Yeah, so when we see under microscope there is crescent formation, we can easily remark it as RPGN. Now again, depending upon the type 1, 2, 3, 4, we have to identify the underlying cause from the above battery of investigations. So we will further, what will we do? We will do immunofluorescence. So immunofluorescence will help whether it is type 1, type 2, type 3 or mixture of type 1 and type 3 clinically as well as immunofluorescence, and we will designate it as type 4 if there is mixture of 1 and 3. So type 1 is anti-GBM, so we will see antibodies against glomerular basement membrane in linear arrangement, and those antibodies are IgG and C3. Anti-GBM antibodies IgG and C3 are coating the GBM, are linearly arranged in a linear pattern. In type 2, okay, there is granular glomerular staining of different type of immunoglobulins and complements. Okay, it is immunologically mediated, the immune complex mediated type 2. Type 2 is deposition of immune complex. That immune complex consists of not few immunoglobulins but different immunoglobulins. The difference morphological feature in type 1 and type 2 is, in type 1 there is linear arrangement of particular immunoglobulin and particular complement. In type 2 a complex is formed of immunoglobulins as well as variety of complements. Okay, in 3 we see very few immune complex, that's why we say post-immune. Either there is no complex or very mild. Alright, so this is immunofluorescent picture, which it is difficult for you to understand, but still you can try. This is glomeruli, and there is linear staining of IgG, immunoglobulin G, okay, in the basement membrane of the glomerular. You can see the glomeruli. Here the staining is granular, not diffuse. Here the staining is diffuse because entire GBM is affected. And background is very scant. The immunofluorescence stain is very scant in this post-immune type. It is looking dull. Okay, so instead of considering the picture, you have to understand these 3 markers: linear, granular and post-immune deposition. If we do electron microscopy, we don't see electron dense immunocomplexes in type 1 and type 3, and multiple electron dense deposits can be seen in type 2. So basically the diagnosis depends upon demonstration of crescent under H&E stent sections in biopsy and immunofluorescence test. So these 2 tests, light microscopy and renal biopsy and immunofluorescence. Okay, so electron dense deposits very few are seen. Serology, as I said, how you are suspecting the disease with the clinical features and whether it is type 1, type 2, type 3, type 4, depending upon that. So if it is anti-GBM, then there are you can find the linear immunofluorescent deposition of immunoglobulin G. Okay, IF means immunofluorescence. Now how will you get idea clinically that it can be anti-GBM antibody? The patient, apart from the renal, altered renal function test, dysmorphic RBC, okay, microscopic hematuria, anti-GBM antibody also present with hemoptysis, lung hemorrhages. It also affects lung. So that can be one associated clinical feature, and this is also sometimes asked, right? IgA, anti-GBM glomerulonephritis is a part of good pasture syndrome, which presents with the lung hemorrhage or hemoptysis. All right, if there is no hemoptysis, then it is anti-GBM glomerulonephritis. If there is hemoptysis, then we have to see for good pasture syndrome. So these are different tests, different serological tests to rule out, and it is just to get an idea, and actually you don't need to just do operation behind that. You are supposed to understand the crescent and the immunofluorescence. So what is this crescent now? This crescent is, as I said earlier, it is accumulated cell, the cell proliferation of fibroblasts and visceral epithelial cells that gets accumulated in the shape of crescent in Bowman's space. The Bowman's space is obliterated, which appears as periglomerular space. If you see normal glomeruli, there is some space between the glomeruli tuft and the Bowman's capsule, isn't it? So that space is known as Bowman's space. See this left side space, the free space. Okay. So in conclusion, RB's genes should be remembered as crescentic glomerulonephritis, and accordingly the morphology should be evaluated. The right side picture is of lung, where anti-GBM antibodies cross-reacts with pulmonary alveolar basement membrane and cause good pasture syndrome. So this is also a question that anti-GBM antibody disease is associated with which disease. So Answer will be Goodpasture syndrome. Okay, post-immune is associated with vasculitis. Immune complex diseases are also associated with vasculitis. So you just need to know the name, the microscopic polyangiitis, vaginal granulomatosis, and Strauss disease. So with some data, and that's the end of the class. That there will be immunofluorescence findings. Any questions till now? Anything you haven't understood? Well, while we teach you, we give you lots of information, and then you have to revise it and you have to summarize it. Okay, summary should be as per the curriculum, because when we follow the curriculum very strictly, many things a medico should know and understand is missed. Okay, so sometimes we overlook the curriculum, and we teach you the battery of things, but you have as per the exam, and I know you follow the fast track only, which is very much curricularized, but still you should know the right and left portions of the things. Okay, and you must know, irrespective of the curriculum, the renal function test. So today's homework is you all read renal function test, and we will discuss it in the next class. Okay, clear?
Yes, ma'am.
Okay, so this is end of the class. Thank you.